Thank you, Dr. Muffitz. Can the MC qualify to stay in to enter the quiz as well? Okay, thanks. Okay, so before we start off, my words of Benjamin Franklin: tell me and I forget, teach me and I may remember, involve me and I will learn. So please make this an interactive session. There'll be a lot of question and answer session. So make this interactive and get the most out of it today. And there's also a book to be won. Okay, so let's proceed on to the first symposium. I'd like to invite the chairperson of the first symposium, Dr. Ling Kwong Ng, who's a senior consultant anesthetist from Ara Damansara Medical Center, Ramsay Sime Darby Hospital. He's also a former lecturer of University Malaya and instrumental in establishing regional anesthesia in University Malaya, and also one of the pioneers of the special interest group of regional anesthesia. A warm welcome to a first chairperson who will chair the symposium on blocks for major joint surgeries. Let's put our hands together.
Good morning, ladies and gentlemen. It's good, so nice to see so many of you here today. Our program today is actually quite packed, so we will start our first session without delay. The first session we are talking about a block for major joint surgery. We have two speakers here. First speaker will be Dr. Shinichi Sakura, and the second one will be Dr. Bechara. First, I will introduce Dr. Shinichi Sakura to you. Dr. Shinichi Sakura is a professor from the Shimane University Hospital, Izuno City, Japan. Dr. Shinichi Sakura has been with us for the past 4 years of the RA Asia, and he mentioned that he will introduce himself more, so I will keep it short here. So let's welcome Dr. Shinichi.
Thank you for the kind introduction. Good morning. This is my third visit to this beautiful country, and this is my first visit to this unique city. I'm very glad to be here to speak to you today. And my name is Shinichi Sakura, as Lin told you. And I'm an anesthetist working at Shimane University Hospital in Japan. For those of you who don't know where Shimane is here. This is Japan. I came from right here. My town is very small, not like Tokyo, but quite laid back. And we have a number of things that we are proud of in Shimane. For example, this is a castle nearby. In 3 weeks, this castle gets surrounded by beautiful cherry blossoms like this. And we also have a big old Shinto shrine in my town, which is one of the most prestigious shrines in Japan and attracts a number of tourists, especially women, because the god there helps find their ideal soulmate, you know, Prince Charming. And in addition, we have a fantastic hot spring resort and delicious food that you could really enjoy. So please visit us someday. Okay, turning attention to medicine. Oh, okay. Shoulder joint surgery is thought to be one of the most invasive orthopedic procedures. Among shoulder surgeries, rotator cuff repair is performed most frequently. Rotator cuff consists of supraspinatus, infraspinatus, teres minor, and subscapularis muscles. And one of the when a tendon of these muscles is severely torn, rotator cuff repair is conducted. Small rivets called suture tendons are often used to help attach the tendon to the bone and cause severe pain. Nerves that provide sensory innervation of the shoulder joint are mostly supraclavic, scapular nerve, and axillary nerve. Other nerves that contribute to the sensation in the shoulder joint include lateral pectoral nerve, and musculocutaneous nerve, and suprascapular nerve. As you know, the brachial plexus is a complex network of nerves consisting of the ventral rami of spinal nerves through from C5 to T1, and the scapular and actually nerves are the branches of C5 and C6. So when you want to reduce the pain in the shoulder joint, you need to block the afferent nerves here. So the InterScaring approach to the brachial plexus block is the best choice. Actually, InterScaring brachial plexus block has been used for shoulder surgery for many years. However, there is a relative paucity of high-level or randomized control trials addressing the benefits of InterScaring brachial plexus block in shoulder joint. This is not a comparative study, but can tell us how patients feel about the perioperative management with InterScaring block. And procedures range, widely range from major surgery like rotator cuff to minor ones. But patient over 99% of the patients felt satisfaction with the treatment of anesthesia with InterScaring brachial plexus block. So that is good. Then why do so many patients feel satisfied? This systematic review searched for studies between 1950 and 2012 and evaluate the effects of InterScaring brachial plexus blocks in patients undergoing shoulder surgery. And they found that the use of an InterScaring brachial plexus block resulted in significant decreases in post-operative pain scores and in the amount of supplemental analgesics and being effective. So the patient satisfaction may have resulted from reduction in pain, post-operative pain. Early mobilization is very important in successful rehabilitation. Post-operative pain prevents effective physiotherapy. So decreasing post-operative pain with InterScaring block theoretically improves early rehabilitation. These authors wanted to prove this by comparing continuous InterScaring blocks with intravenous opioid injections. And they used a constant score to assess functional disorders of the shoulder joint, including pain, sleep disturbances, and quality of the patient's daily life activity. And they found that the constant score decreased post-operatively in both groups, but the decrease was significantly less extensive in patients receiving this block. However, when you look at each category of the scores here, strength and range of motion were similar between the two analgesics, between intravenous opioids and the InterScaring blocks. So that means significant difference in constant score only resulted from lower degrees of pain in the block group, and superior analgesia did not necessarily lead to improvement of early rehabilitation in patients undergoing open shoulder surgery. So this is a little bit disappointing, but I believe that some of the blocks they did were not working properly because the block technique they used in for this study was not ultrasound guided. Still, we can see patients receiving blocks reported lower degrees of pain intensity at rest and as well as during exercise for the first 3 postoperative days. This post-operative study was conducted to obtain data from a large national cohort between 2007 and 2011. And the authors wanted to see how frequently perioperative peripheral nerve blocks were added to general anesthesia in patients undergoing total shoulder arthroplasty. And they also wanted to see if there were any differences in the risk for major perioperative complications and mortality between patients who received the block and those who did not. And they found that similar, out of more than over 17,000 patients, 20%, only 20% received the peripheral nerve blocks. This is not good. But still, they found that, and they also found that there was no difference in the mortality and the instance of major mortality, major complication like this, regardless of the block. So again, there must be some technical problems in this study too by using traditional techniques. So we need to improve the quality of the block by using ultrasound. So first, let me talk about the single shot first. InterScaring block. The cervical nerve roots are sandwiched between the anterior and InterScaring muscles, which correspond to the lateral edge of the sternocleidomastoid muscles. Large vessels are usually outside the group and can serve as a landmark for this block. This approach also blocks the supraclavicular nerve and the phrenic nerve. And most of the time. The reason why you can block the supraclavicular nerve is that this nerve runs behind and comes out from the edge of the sternocleidomastoid muscle. I think this is actually good. With this block, you could actually provide anesthesia on the shoulder, on the skin over the shoulder as well. So that this is good. Position the transducer this way, and you can observe an image like this. You can identify the sternocleidomastoid muscle superficially, and deep to it, the anterior and the middle scalene muscle. And you can see 3 nerve roots here that are dark or hypoechoic in the interscalene groove. And you can also identify carotid artery, which is not seen here, and the interjugular as well. So then you need to insert a needle, but where should you put the needle? So this is the ideal spread of local anesthetic after injection. So this is a paper showing the cervical nerve roots and the proper location for the needle tip. The labelings in this picture show that these superficial two are C5 nerve roots, and this one is C6, and this one is C7. However, the labeling turned out to be wrong later. Actually, this is C5, and these two are C6, and this is C7. Now, recently, Franco clearly showed in his cadaver study results that the C5 root is significantly smaller than either C6 or C7. And also, C6 roots split quite early, like this. So this is C5, and this C6 is larger and split earlier. So are you going to advance the needle space here or space here after the bifurcation? No, I like to point a needle tip underneath the C6 because there is a wide open space here. But a problem has still come up, That is, you cannot steer the needle away from the nerve all the time, even if you try to. This, for example, this is Liu and his colleagues conducted a prospective observation study using 257 patients and who received ultrasound-guided InterScaring supraclavicular blocks. And they, in this study, they placed a needle tip only adjacent to the target nerve. And after checking the video later, they surprised to see 17% of the patient had received local anesthesia intraneurally. So intraneural injection occurs before night. Fortunately, no one developed clinical nerve injury afterward. So it makes sense that some anesthesiologists have thought of a way to avoid unintentional intraneural injection by taking a more conservative approach, which is avoiding needle-nerve contact. When Spence and colleagues conducted the InterScaring block, they advanced the needle not into the brachial cyst, but to outside of it, and injected local anesthetic in a space between the middle scary muscle and the brachial plexus cyst. They actually compare this conservative technique with conventional but aggressive technique that allows injection within the cyst. And they found that their conservative technique resulted in similar block onset times and block quality as compared to the conventional one. This table shows the percentage of patients with normal sensation in these four nerves 10 minutes after the block. And as you can see, the two techniques produce similar blocks. So you better to conduct this block conservatively. So I recommend that you advance the needle until the tip barely past the fascia, but not inside the sheath. Another problem is injecting a certain amount of local anesthetic into the groove here, this way. You also block the nerve, phrenic nerve running here, like this. So Philippe Gautier injected a small amount of 10 ml of radio contrast solution in the InterScaring spaces and saw this medium spilled outside the groove and surface of the InterScaring anterior scaling muscle, where the phrenic nerve is. Researchers in Lausanne conducted this randomized study to see if they can reduce the incidence of hemidiaphragmatic paralysis by injecting anesthetic lateral to the brachial plexus sheath compared with the conventional intrafascial injection. And they used 20 ml of 0.5% of bupivacaine and found that their intrafascial injection technique resulted in significantly smaller reduction in the ventilatory function, including these, compared with the conventional technique. Although the block fascial injection, intrafascial injection technique resulted in significantly slower onset, both sensory and motor block. Both techniques, both injections produce similar analgesic time course. Other nerves can be damaged too. Okay, this is in ultrasound image showing the dorsoscapular nerves and the long thoracic nerves. Dorsoscapular nerve originates from C5, and long thoracic nerve from C5, C6, and C7. So, in fact, these nerves can be seen quite frequently when you sit. And as you can see, when you perform lateral approach, you need to be careful not to injure these nerves. Serious adverse events include epidural block, total spinal, and permanent neurological complications. According to these case reports, intercord injection, horizontal needle insertion technique, and performing the block during general anesthesia were responsible for this, for the serious complications. So I would like to advise against conducting this block in an anesthetized patient. So there is a question in the first place whether this single block, single short InterScaring block benefits patients. The authors of this paper analyzed the result of previous studies comparing a single short InterScaring block with no block, usually general anesthesia alone. This shows the difference in pain intensity between the two blocks for 48 hours after surgery. And below zero means the single injection, single shot ISB is better. And the above zero means worse. And they found that for the first 8 hours, pain intensity was lower in patients who received the block. But after that, around 20 hours after surgery, probably because the anesthetic effect disappeared, they had stronger pain than those who did not receive block and experiencing rebound pain. So we need to do continuous block. However, although the continuous block can benefit patients, it may also cause serious consequences. This report described the most shocking event that has happened in patients receiving a continuous InterScaring block. The patient was a healthy 20-year-old male who underwent rotator repair with general anesthesia. InterScaring block was provided before anesthesia using a single shot of bupivacaine. And then a catheter was introduced through the needle and advanced 7 centimeters beyond the needle tip. At night of surgery, anesthesia resident visited the patient in the room and found that the patient was fully awake, complaining mild pain. So that the patient the resident injected bupivacaine 10 ml through the catheter and left the room, left him after a short stay. But in the next morning, the patient was found dead. And the post-mortem scan, CT scan revealed that the catheter tip was inside the canal, suggesting that the patient had developed total spinal anesthesia. So you can easily tell the possible problem in this case. Those are the block was performed with readings approach, so that which means the needle was inserted immediately, and the catheter was advanced 7 centimeters beyond the needle tip, and the first bolus was injected through the needle, but not through the catheter, and first bolus injection through the catheter was made without preceding infusion. So this case report tells us that we must observe a guideline like this when you provide continuous InterScaring block. You should direct the needle laterally, and do not advance the catheter 3 centimeters, more than 3 centimeters beyond the tip. And the first bolus injection should be injected through the catheter, not through the needle. And you should stay at the bedside for a long time after making a bolus. Regarding the needle insertion, there are 2 techniques, actually, out of plane and in plane techniques. So with out of plane technique, please do not advance the needle too deeply. I think 1.5 centimeter would be enough. It is better to place the needle tip on the lateral or posterior side of the groove because most of the nerve, sensory nerve fibers are on this side of the roots. If possible, you should observe the catheter going like this under the ultrasound. And it is strongly recommended that you use a dowel needle. Although some people feel against it, we actually conduct posterior approach a lot because with this approach, the catheter can go through thick muscles and can be secured quite easily. So the needle is goes like this. Make sure that the tip goes to the right place. Here, the tip is positioned between C5 and C6, which is actually okay, but I suggest you aim the needle here where you have much wider open space, which means underneath the C6 root. Okay, you need to push in the catheter farther while putting the needle out. And because the tip is going to draw back a little post-operatively, even if you secure the catheter at the insertion site, because the neck is going to swell up after surgery because of the inflammation, something like that. Continuous block does not always function because of head and neck movement. These catheter may be pulled out accidentally or migrate after insertion. And if it occurs, the analgesic effect may decrease. So it is very important to secure the catheter with tape as well as dressing or draping because during operation, this area gets wet. As I said in the beginning, the shoulder is innervated mainly by suprascapular nerve and axial nerve. So blocking these terminal branches should provide some analgesia in the shoulder. For axial nerve block, you place the transducer on the posterior aspect of the proximal upper arm, like this, and you can see the humeral posterior circumflex humeral artery between deltoid and teres minor and triceps muscle. The scapular nerve is right next to the artery. No, axillary artery. Axillary nerve is right next to the artery. For scapular nerve block, you should place the transducer on top of the back like this to observe the image like this. So you can see trapezius and spinatus muscles and suprascapular notch. And in the notch, you should expect to observe the suprascapular artery and the nerve is right next to the artery. However, I have to say that the combination of those two blocks is not as effective as InterScaring block. This paper shows the result of a study comparing the compare the analgesic efficacy of the combined block with InterScaring block after arthroscopic surgery, including rotator cuff repair. And they found that they used actually 15 ml of ropivacaine and 20 ml of the same solution and for the InterScaring block. And they found that the InterScaring block provided better quality pain relief at this way and fewer adverse effects for the first post-operative day. So it is fair to say that the combination block is suitable for pain only after minor shoulder surgery. So finally, I want to say that when you conduct peripheral nerve blocks, you always have to strike a balance between these two, success and safe. Well, thank you very much for your attention.